I've been asked to provide an immunisation update, and I thought what I'd do is just talk about the work that we are focusing on in the immunisation unit for the coming year. So today, what I'm going to talk about is three main areas that we're focusing on: targeting pertussis, improving timeliness and vaccine coverage rates in our childhood programme, and expanding immunisation education for health professionals. Because of the cyclical nature of pertussis disease every 3 to 5 years, we can be guaranteed there's another epidemic coming fairly soon, and we want to be prepared for that. So we aim to target pertussis by improving timeliness of receipt of that first dose of pertussis-containing vaccine. And as many of you know, that first dose of pertussis-containing vaccine is in combination with 5 other vaccines: Hib, hepatitis, polio, diphtheria, and tetanus. And it's presented as Infinrix Hexa, and that's what's purchased for Australia. We want to raise awareness of the recommendation to vaccinate pregnant women against pertussis in the 3rd trimester of their pregnancy in order to provide protection to their baby in the early months of life. And we also want to improve vaccine coverage rates in the childhood programme, especially in the 4-year-olds, but particularly for Aboriginal children in that first year of life, so that those early vaccines just after they're born. We also want to expand our reach with immunisation for education for health professionals, because immunisation goes right across the life cycle, from the cradle to the grave, and it's more than just people in general practice or local councils that are working with immunisation. It's hospitals, it's community health services, it's right across the health sector. So first of all, targeting pertussis. Well, there's ample evidence from Australia as well as internationally that indicates the timing of that first dose of that pertussis-containing vaccine is critical. Vaccine effectiveness following dose 1 is around 55%, which can effectively halve the risk of hospitalisation from pertussis in babies at the 2 to 3 month mark. And effectiveness, of course, increases with the 2nd and 3rd dose. Now, this was our schedule last month. It was the orange schedule, and the schedule point for that first DTPa vaccine was 2 months of age. Now, in response to the sustained outbreak of pertussis that we had in 2009 right through to 2011, ATAGI recommended that that first dose of pertussis-containing vaccine actually could be given from 6 weeks of age, and that that 4th dose, so that booster dose of pertussis vaccine delivered at 4 years of age, could be delivered earlier from 3.5 years of age. So we included this message in our schedule, and as you can see in the comments section, this information was provided. However, the message was slow to get through to providers. I'd like to acknowledge the National Centre for Immunisation Research and Surveillance for providing permission for me to use this graph. But the graph shows the percentage of children receiving their first dose of DTPa vaccine, aged more than 6 weeks but less than 8 weeks. And it's by jurisdiction and month of receipt. It only goes up to, 2012. I'm afraid. So starting from January 2009 through to 2012. So this early timing, early receipt of that first pertussis vaccine, New South Wales and Tasmania, you can see, were off the mark really quickly, and I think they were really struggling with the disease at that time. South Australia hasn't done too well. But round about October, we started to take off, and we're going up to about between 40 and 50% of children receiving that first dose of the pertussis vaccine before they turn 8 weeks of age. So we would actually like to do better than that. So our new schedule, as of October, is the blue schedule, and we've changed that 2-month schedule point to 6 weeks or 42 days. So it's a much stronger message that we're getting out there. You have a schedule in your pack if you wanted to look at that. Work by Helen Quinn and her colleagues from the National Centre for Immunisation Research and Surveillance, NCIRS, shows that bringing forward that first dose of pertussis from 8 weeks to 6 weeks of age reduces the average pertussis notifications in the 2 to 3 month olds by 8% and hospitalisations by 9%, with larger reductions in the epidemic year. So it's a really good move to bring that vaccine forward those 2 weeks. It's accepted on the Australian Childhood Immunisation Register, but please don't be tempted to bring forward the following vaccines at the 4 months and the 6 month mark. They need to remain at 4 months and 6 months. And you have to keep in mind that the pertussis vaccine is delivered in combination, and hepatitis B is one of the vaccines in the combination, and that has specific rules about when dose 1 and dose 2 and dose 3 are delivered. And the immune response to the primary course could be compromised if dose 3 is delivered less than that 6 month mark. So once you deliver the 6 week vaccine, don't be tempted to bring forward the 4 month and the 6 month vaccine. Now we need to make sure that this message is actually put out to other areas that are working with pregnant women and young children, especially babies. So we're looking at incorporating this change into the South Australian perinatal practice guidelines, specifically in the GP shared care protocols, because at the moment it talks about at the 6 week point you do a baby check and you discuss immunisation. So this needs to change now, where immunisation has to be administered at 6 weeks. So getting the message across about the 6 week vaccine to parents needs to happen as well. And because they need to be making the appointment after they get home from hospital fairly quickly, making the appointment with their immunisation clinic for that 6 week mark. Well, almost 70% of births in South Australia are registered with Medicare Australia within the first 28 days. So it's an ideal opportunity for us to send a message out to those parents to remind them to get their child vaccinated at 6 weeks. So we're having our Chief Public Health Officer write a letter to parents advising them of that step to take. So continuing to target pertussis, we're looking at maternal vaccination against pertussis. Now, the adult formulation of pertussis is different to the childhood formulation. It has a reduced amount of diphtheria and pertussis antigen, and that's why it's expressed as a small d and a small p. The vaccine is on the National Immunisation Programme. It's funded as a single dose for students in high school, and it's delivered in Year 8 as of 2015 in South Australia. It's delivered in Year 9 this year. It's an inactivated vaccine, and there's 2 brands available. There's the GSK brand, Boostrix, and that's the brand that we use for the school programme. And there's the Sanofi Pasteur brand, Adacel. Now, the current recommendation for pregnant women is the 3rd trimester, but it states in the handbook as an alternative to postpartum or pre-pregnancy. However, this vaccine has been used in the US since 2011 and the UK since September 2012 in a huge funded programme for pregnant women because of the pertussis epidemic that they were experiencing at that time. It is routinely recommended for pregnant women in both these countries as well as in New Zealand and in Belgium. Now, information from various studies indicate that it's safe for use in pregnancy. Indeed, the recent study reported from the UK indicates maternal vaccination using the adult pertussis formulation, the DTPa, in the third trimester is more than 90% effective at reducing pertussis disease in infants up to 3 months of age. And there'll be more information presented in Dr. Anne Kohler's presentation that's going to be following this about that particular study. I need to point out, though, that it has been suggested there is the potential that the maternal pertussis vaccination given during pregnancy has the potential to interfere with the primary immune response to pertussis in the child, and that it's been suggested that there may need to be an additional booster vaccine given to cover the second year of life. So that may require a DTPa vaccine at 18 months of age for children born to women who have had the DTPa in the third trimester of pregnancy. So maternal vaccination, getting the message across, because traditionally the message has been that pregnant women should avoid vaccination. So we need to raise the awareness in pregnant women about pertussis vaccination. And we're going to do that by making changes to the pregnancy record. It already states in the pregnancy record that influenza vaccination should be discussed at the first visit, and we now need to include pertussis vaccination. How vaccination for pregnant women is discussed in the perinatal guidelines, we think needs to be looked at more closely now. There is some information in the preconception guideline, but it doesn't cover all the relevant vaccine recommendations. In the GP shared care protocols, influenza vaccination is discussed during pregnancy, but that now needs to include pertussis. Interestingly, the management of obese pregnant women, and we've heard a bit about that today, the guideline for managing obese pregnant women does not mention influenza vaccine, yet both obesity and pregnancy are risk factors for complications from influenza. So immunisation for pregnant women may need to have its own guideline to ensure the discussion on immunisation needs for pregnant women takes place antenatally as well as preconception. In addition to this, we're planning a communication campaign to get the message out to pregnant women, to get the message out about the pertussis vaccine during pregnancy, and also that 6-week schedule change for their baby. How that communication plan will look, I'm really not sure. We're working with a creative agency from WA, and they are currently looking at the behaviour and attitudes of pregnant women. They're looking to see what they read, what they buy, where they shop, and they're going to come up with something wonderful, I think, that's going to allow us to get the message across to pregnant women in South Australia. We're also updating our immunisation resources for pregnant women. So once we have raised awareness of the value, the benefit of immunisation against pertussis and influenza and pregnancy, will pregnant women accept vaccination? Well, uptake of flu vaccine for this group, and it's recommended and funded, is not really fully known, but it's estimated to be around 30%. However, outcomes of a New South Wales study by Kerry Wiley and her colleagues at the National Centre for Immunisation Research and Surveillance, and reported in the journal Vaccine, concluded that most women reported a willingness to have the pertussis vaccine during pregnancy should it be recommended. Compared to those who had not received a recommendation to have the vaccine postpartum, women who had received a recommendation were 7 times more likely to report intention to have the vaccine. So I just wonder whether the vaccination is actually being recommended if we've got such a poor uptake of the influenza vaccine. And I think if we're going to move forward with a recommendation for pertussis vaccination in the third trimester, and we want good uptake. I think in the UK the uptake was around 60%. But we're going to need to have the service providers that are working with pregnant women to actually make that recommendation. So it would appear that pregnancy itself is not a barrier to vaccination if the recommendation is there. Barriers tend to be around cost. And of course, the vaccine is not funded at the moment. It is funded as part of a state-funded programme in Queensland. It's being delivered through their GPs and soon to be through their antenatal services. The uptake, they're not sure. It's been a bit slow, but it takes a while for new recommendations to filter through and for people to become confident of the programme. When the vaccine was first registered, of course, there were no clinical trials done on pregnant women, and therefore it's not in the product information as an indication for use in pregnancy. So in due course, this is likely to change with the outcomes of this study from the UK. And we hope to see that there would be a submission put before the Pharmaceutical Benefits Advisory Committee, the PBAC, to fund the vaccine. So continuing to look at targeting pertussis, we really just want to ask a question here. Should we be considering replacing ADT with the DTPa vaccine in emergency departments and also in the GP's doctor's bag supply for managing tetanus-prone wounds? I was an emergency room nurse at the time when tetanus toxoid was taken out of the fridges, and it was replaced with ADT because diphtheria was a problem. So I think maybe it's time we start considering if pertussis is getting out of control, as Tom Snellen referred to this morning, that we maybe need to look at other measures like this. So there are some of the strategies we aim to put in place to try and improve protection against pertussis when this epidemic that we know is actually going to hit us. The next area that I want to talk about is continuing to improve coverage and timeliness in the childhood programme. And again, our speakers this afternoon have talked about the importance of the timeliness in vaccination and the fact that it is a problem for us. We've got a few campaigns that are running at the moment, and we've also got a trial where we're working with BioCSL. The first campaign that I'll talk about is A Big Help for Little Adventurers, and I think you've got to be living under a rock if you don't know about this programme yet, because I see the kids walking around Rundle Mall with the koala mask on. But this was a campaign aimed to try and get the message across that that 4-year-old vaccine could be given from 3.5 years of age, because at that time our 4-year-old coverage rates were probably the lowest in Australia. So the campaign centred around a book about a young boy going to have his booster vaccines before starting kindy. I'd like to say that the name of the boy was a nod to our health minister, but it was in 2011 and John Hill was our health minister at the time. So the tagline was kindy kids are ready for more, get their boosters before age 4. So it was all about trying to get them vaccinated early, and it commenced in August 2011. And I've got another wonderful graph from the NCIRS that they have given me permission to use. And this, again, shows you it by jurisdiction and going along to the end of 2012. And you can see that in the middle of the 2011, we started to take off, and we're the leader of the pack now. So we're hoping that we've maintained that, but we're not sure. We're going to have to get more data from NCIRS. So there were a few things that were going on at that time. There was a few different strategies, national strategies, the splitting of the payment, the childhood payment at 18 months and 4 years of age. So there was a few strategies happening nationally, but I would like to think it was the South Australian strategy that got us ahead of the pack. Okay, let's take a moment to look at vaccine coverage in South Australia compared to the national average. Now, this graph shows the percentage of children fully immunised in all 3 cohorts. The solid lines are the South Australian coverage rates, and the broken lines the Australian average. Now, the red line is children aged 12 to 15 months of age, and it's around 91%. Now, this coverage is an assessment of those vaccines that are given at 2, 4, and 6 months of age. The green line shows coverage of children at 2 years of age and assesses the vaccines due at 12 months of age. The blue line, as you can see, South Australia way down here at that particular time, is assessing the vaccines given at 4 years of age. And that's the coverage as they turn 5. Now, looking at that graph, we would say we're doing pretty well, really. We're in all 3 cohorts, we're between 91 and 93%, with the 2-year-olds the highest at round about 92%. But that's not the whole story. It takes a while for new vaccines to be picked up and included in the assessment by ACER as fully immunised. And we need to do that because it does take some time for the acceptance of new vaccines by providers as well as by the community. Maybe it's taken us a little bit longer than we expected to have it included in the assessment, but it's close to be included in the assessment. But this green line, where we've got 92%, is not including meningococcal C vaccine in the assessment, and it's not including varicella vaccine in the assessment. That's about to happen very soon, but what is going to happen to our coverage when it does? So the blue line at the top is measuring, that's the 2-year-old coverage, and that's the national coverage. This is all the national coverage. When we include meningococcal C, you can see that it's very, very close, so it's not going to have much of an impact. But when we include varicella in the assessment, that drops from almost 92 to 87%. Now, that's quite a significant drop. So it's going to be important for us to encourage parents to come back for that 18-month vaccine, because our varicella vaccine is delivered now with that second dose of MMR, and that's very important to ensure that children are fully immunised against measles. It's also important for Aboriginal children, that 18-month mark, because the Aboriginal children in South Australia should be receiving hepatitis A at 12 months of age and again at 18 months of age. And I'm not going to show the graph for our hepatitis A coverage because it's too embarrassing. Our graph is around a 30% coverage for 2 doses, and that's just not good enough. The second campaign that I'll talk about is our Help Me Stay Strong campaign. At the end of 2011, South Australia had the lowest coverage rates in Australia for Aboriginal children, particularly those vaccines in the first year of life, those 2, 4 and 6 month vaccines. Now, again, we've heard today about the risk that Aboriginal children are at for disease, and that delays in vaccinating them continue to place them at risk. So we set about with a creative agency, came up with this campaign, and it's a pack that has baby grows that have, they get me immunised. They're baby grows that fit them at 2 months, 4 months and 6 months. And it's about, get me immunised, I'm now this age, get me immunised. There's a little a pram play toy that has it on each of the sides of the cube. And it has magnificent images of Aboriginal children. So we introduced this campaign in the middle of 2012. At the same time, we employed a project officer to look at improving our Aboriginal coverage rates. Now, the project officer that we're working with currently works from our office, but goes out and works with health services across South Australia. And she has been running reports from ACER using identifiable data to find out those children that are overdue for vaccination, and then she rings up their last service provider and asks them to actively follow up these children. And then she follows up with the service provider to see if they've done that. She also goes on the ACER and makes any amendments, any corrections to the information that's been reported to ACER, because that's a problem. And we've identified that clearly it's a problem, the way that the ACER is set up, where you have multiple generic type vaccines that they have to choose from, and where you've got DTPa, Hib, Hep B, IPV, and then DTPa, Hib, Hep B, and then another DTPa, IPV, providers, it's easy for them to select the wrong one, and if it's the wrong one that's selected, then the child comes up in the coverage as being overdue. So there's been a lot of corrections that have been done on the ACER as well. The other thing that Adrienne is doing is she's encouraging a recall system. She's helping providers develop recall systems. And if you have Aboriginal children come into your service, she's getting them to use these postcards so that they can make a note of when the child is next due for their vaccine, and the service provider sends out the postcard just prior to when they're due to remind the parent to bring the child in. So let's look at our vaccine coverage for the 12 to 15 month mark. This graph compares vaccine coverage for those Aboriginal children at 12 to 15 months compared to non-Aboriginal children, assessing those 2, 4 and 6 month vaccines. The work that we've been doing, it takes a while for the data to flow through to the ACER reports that we receive. But as you can see, from the beginning of 2013, where we were just above the 70%, we have been heading in the right direction, where we're getting close to 90%. So we're getting closer to closing the gap, but we're not quite there yet. The other area that we're really focusing on is education. And that's because I really believe that education is critical for health professionals now. As I said earlier, immunisation is happening everywhere, and it's happening right across the life cycle. And there's more and more immunisations on the schedule. There's more and more out in the wings that are looking at coming on the schedule. And people are asking questions about immunisation because there's so much information out there. We know that uptake of vaccination is dependent on confident conversations with their health service provider. So the health service provider needs to be confident themselves about the immunisation discussion. So we're looking at educating Aboriginal health workers. We believe they are key in helping with timeliness in the Aboriginal community. We're working with the Aboriginal Health Council of South Australia. We've developed an education programme. Mel, there in the audience, has been busy for weeks developing this programme, and she's going to be delivering the start of it tomorrow. So we're really excited about that, getting into that group of health service providers that are really key. We also want to get talking to midwives, because I think it's time now that midwives start to get involved in the immunisation discussion. I'm not sure how confident they are about discussing immunisation, but it's now becoming part of their role, with that maternal immunisation happening and also with that neonatal vaccination happening, at the 6-week mark. So we want to talk to the midwives and get an education programme for them. We've got the practice nurses covered because we've got an online immunisation education programme available. Now in South Australia, we believe that education should be easy to access and it should not be cost prohibitive. It shouldn't be stuck in the universities where it costs $2,000 and it takes 6 months to complete. You should be able to go on and find out quality information in your own time at a minimal cost. We've got information in your pack about the online education programme, but every practice nurse should be doing this programme so that they can confidently talk about immunisation. This just tells you, we had this programme running, we've had it online for about 9 months, and this just is my final slide. And we've had a total of 866 registered users. This just shows you which jurisdiction is using it. It's an approved programme in South Australia and Western Australia, and the majority, of course, is South Australia, but we're getting a lot of uptake in WA, and there's nibbles from the other states and territories as well. So where to next? Well, we've heard about the influenza vaccine for Aboriginal children less than 5, the possibility of an 18-month DTPa. There could be zoster vaccine out there for the elderly, meningococcal B, babies and adolescents if Helen gets her way, quadrivalent influenza, flu mist that was talked about earlier, and the Canadians have been working on an Ebola vaccine, so maybe that. So it just leaves me to say now thank you to my team who are behind all of this hard work. I get the pleasure of standing up here to talk to you about it, and that's me finished. Thank you.
Thank you very much. You've got statistics on Aboriginal uptake for vaccines for children. Have you got any statistics on the uptake in newly arrived families for their children?
No, I'm afraid we don't. These are the refugees.
Yeah.
No, I'm afraid we don't. That would just be, they'd have to be on Medicare Australia, they'd have to be on the register for them to be included. What we do have statistics on are the number of vaccines that we send out for use in that group, because it's a state-funded programme, but that's all that we would have, the vaccines that are distributed, and it's not a really good indicator.
South Australian statistics for Aboriginal coverage, does that include the APY lands or not?
Oh, there's a problem with the APY lands, because the APY lands are actually, South Australia is responsible for the immunisation that's happening in the APY lands, so we're responsible for the education, all the resources, but the registration of newborns on Medicare Australia, on the ACER, a lot of them use the Alice Springs postcode. So they get reverted to the Northern Territory coverage. And the Northern Territory have wonderful coverage. And I think if we could include them in our South Australian coverage, it might actually make ours look better. So we're working on that as well.
Maureen, sorry, it's Michelle Clark here from Helen's group. I've just got a quick question
Sorry, I can't see where you are.
Sorry,
oh, there,
yeah.
okay.
What would your recommendation for maternal pertussis vaccination be in terms of should they receive it every pregnancy, or only if there's an interval of at least 5 years between previous pertussis vaccination and subsequent pregnancies? And just the second question is about the 18-month booster. Would you recommend that to be an Infamrex IV, but a DTPa, an Infamrex IPV, or just an Infamrex?
Well, I don't want to presume anything, but the ATAGI are going to be probably reviewing, they probably are reviewing it currently. And I'm sure there's going to be an announcement coming out about both of those questions that you've put to me. I don't know whether Anne, who's on ATAGI, and also Helen, who's on ATAGI, and Ross, I don't know what I'm allowed to say, to be honest.
So Ross Andrews from Menzies School of Health Research, not speaking on behalf of the team. There is serious consideration of pertussis vaccination in pregnancy and the recommendations related to that, and there will be something in the public domain quite soon. It's actually a matter of record that's been in the bulletin published on the website about ATAGI reviewing the evidence base for pertussis vaccination in pregnancy, and the 18-month pertussis dose as well. The issue, I suppose, just as a comment for that, it's actually an unrelated conversation to the pertussis vaccination in pregnancy. The rationale for looking at reintroducing pertussis dose at 18 months is because we've seen increased rates of pertussis at 2 and 3 years, and that's not about the dampening of pertussis vaccination in pregnancy because we haven't had anybody getting it. Some years ago we removed that dose, and I think most people looking at that policy would say that wasn't the smartest move that Australia ever did. Whether it gets back on the schedule is another.
My question is for healthcare workers. Should we have regular pertussis boosters?
Certainly, healthcare workers should be being vaccinated against pertussis, and I think we're slowly moving towards it being a condition of employment that they are vaccinated. How regular that vaccination needs to be, I'm not sure. What are they saying about that, Natalia? 5 years, every 5 years?